My name is Janet Lindau, and I'm here with my partner, Julie Anderson. We are really excited to have the opportunity to tell you about our school-based work, which aims to reduce suicide among adolescents in rural regions of the United States. The reason our organization is so focused on suicide prevention among youth is because suicide is the second leading cause of death for kids aged 10 to 24 years old nationwide. And in Montana, our rate is over 2.5 times that of the national average. Concerningly, data also shows that over 70% of youth who report past year suicidality do not receive any mental health care. This figure is likely higher in Montana, in which 60% of our population live in federally designated mental health care provider shortage areas. Lastly, schools in Montana are not using universal web-based suicide risk screening to connect students with risk of suicide to same-day care in schools. And that's where RBHI comes in. But first, Julie and I would like to tell you why we're so passionate about youth suicide prevention. We co-founded RBHI because both of us have lost family members, friends, and community members to suicide. As a suicide prevention researcher who's worked with communities for many years, it's clear that we are not getting evidence-based solutions to suicide prevention to rural communities. And so that's how I came to RBHI. Julie?
Thank you, Janet. I came to RBHI raised here in Montana in our community and saw that as a child, we continue to have a lot of loss, mental health and suicide. And now as an adult and a middle school teacher, director of our local health department and social worker, we're continuing to see this loss. And Jan and I really felt that we had the tools and the experience needed to really move this dial on our public health issue, which we have here, not only in Montana, but across the United States.
So what are we doing in RBHI? We are working to prevent youth suicide using evidence-based screening linked to care methods, which we've improved in two critical ways. The first is we're using a digital platform which has the FDA recommended gold standard assessment for suicide risk. This assessment can be delivered to rapidly, accurately, and inexpensively screen large numbers of students. In addition to suicide risk prediction, our screening tool also assesses two major risk factors for suicide: depression and anxiety symptoms. So we're not only identifying youths with suicidality, but also those who might benefit from additional mental health care. The second component that differentiates our program is connecting youth with suicide risk to same-day mental health care in schools. We're able to accomplish that both with our therapists that we've identified across the state of Montana, but also through telemental health care, which allows us to do this in rural settings. Lastly, the beauty of our program is that we have a blueprint which can be easily replicated on a state and national level. And now Julie's going to tell you how what screening looks like on a screening day. Julie.
Thank you, Janet. Students complete a web-based screener via any digital device, whether that be a laptop, a tablet, or a cell phone. The screener typically takes 5 to 7 minutes. Those results are immediately sent via email within 1 minute to a designated school staff member. And from those results, students who are identified at elevated risk of suicide are connected to same-day in-school mental health care, as well as long-term referral if deemed necessary. Schools also use this data to inform them for future programming and curriculum needs to further support student wellness and mental health care. Implementation is a 3-step process. Our first step is our preparation phase, where we are engaging school key stakeholders, which are typically administration, teachers, parents, community members. We're also able to tailor the program to suit school needs as well as student population. Our step 2 is actual implementation day of screening, where we're delivering the screening, providing support for schools, and also checking for fidelity and quality improvement. And then our third and final step is really our sustainability phase, where we're discussing further expansion throughout extended grade levels, as well as funding availability for schools to continue screening throughout other years. Last year, we successfully implemented our pilot of this implementation in a freshman class of 41 students. Of those 41 students who were screened, 32% were identified at an elevated risk of suicide. Those students were immediately connected to same-day in-school mental health care. Key takeaways from this pilot project were the feasibility of this in a rural school setting, as well as the ability to identify students who were previously unknown to school staff as having a high need for some mental health support. And the school saw such a great value in this that they have opted to expand screening to include 6th through 12th grade this year. This next slide you'll see is our state of Montana. Our pilot program is our county highlighted in purple. We've also expanded this year to include 4 additional counties. We've identified these counties as having high suicide attempts as well as high anxiety and depression rates. Next year, we're going to further expand to other neighboring Western half counties through 2022-23. And further expansion through 23-24 will really include our entire western half of our state, up to 57,000 students, which are 73% of our eligible students here. And as Janet mentioned, this is a scalable blueprint. We hope to expand throughout our state in 2024, as well as additional rural and urban settings throughout the United States, potentially screening up to 28 million students in grades 6th through 12th grade. Janet.
Thank you, Julie. So now I want to tell you about what we need to expand the program in the way Julie just described. This year, we've raised sufficient funds to deliver in the 5 counties Julie just described, but in years 2 through 4, we'll be expanding to up to 78,000 6th through 12th graders across Montana. And so we're going to need additional staff to support those expansions, and we'll need extra support to pay for that same day healthcare for up to almost 80,000 students. And just to give you an idea of what this costs, it's $46 per student to deliver this per year in Montana. So we really need to raise over $500,000 in year 2, and then up to almost $2 million in year 4 to expand the way Julie just described. And I'd like to end by describing the amazing team of experts that we have at RBHI. So we're really fortunate to have board members and staff who are Montana community leaders, as well as experts in digital mental health care, rural public health, and rural education. Our team of experts guide our efforts, and they'll ensure the success of this program. With that, I'd like to thank you so much for your attention and for your support to reduce suicide among youth in Montana and other rural regions. We'd love to hear from you. Please email Julie or me at the email addresses shown below. Thanks so much.